Okay, so as you may have noticed, the recording, the meeting's being recorded. The chat, I believe, is disabled, but you can chat the co-hosts and the hosts if you have questions during the presentation. We're not going to answer those questions till the end, but you're welcome to put them in the chat. And then before we get to the comments, I just wanted to go over the housekeeping for actually leaving a comment or making a public comment. So everyone's in listen-only mode. You can send a direct chat to the co-hosts, and then in order to make a comment, you would raise your virtual hand during the comment period. We will call on individuals in the order of hands raised. If you're attending by Zoom via the internet, you would raise your hand using the function at the bottom of your screen. You can also raise and lower your hand by pressing the Alt-Y on your computer's keyboard. Telephone users can raise their hands by pressing *9 on the keypad of your phone. Please leave your hand raised until we are able to call on you to give your comment. When we call the name or telephone number of a participant, we will request that you unmute your line, which will appear for internet users as a visual prompt on your screen. And for telephone users, a recorded voice on your telephone should prompt you to unmute your line by pressing *6 on your keypad. Once unmuted, please begin your comment by stating your first and last name, title, and the organization you represent or your affiliation. For example, if you're a member, a guardian, or a stakeholder. Please keep your comments to 3 minutes to give others the opportunity to speak. And at the conclusion of your comment, please lower your hand. This is being recorded, as I stated earlier. When the forum is complete, we will summarize all the comments and sorry, that's not what we're doing today. We're going to post the presented materials and a recording of today's presentation. That notice will most likely go out on Monday, but it will have presentation materials from today and tomorrow's presentation. I believe that's it. So I think we're handing it off to Justin.
Yep. I think I am sharing my screen, but I think Paul is going to kick us off today.
Okay.
So
Yes, I will. So welcome everybody. I'm Paul Associate from the Aging and Disability Office at DHHS. We have a lot of colleagues from the department and also from our partners at Guidehouse on the call today, but in the interest of time, we won't do introductions. We'll just introduce ourselves as we speak. As Amanda indicated, we're going to go through the whole presentation without stopping to make sure we can get through it all, and we have time for your questions. So, and we'll look forward to discussing your clarifying questions and receiving any comments that you have at the end. Let's go to the purpose of today's meeting. Next slide. So today we're sharing part of the nursing facility rate reform proposal that the department is putting forward and that many of you helped us with your input last year. This is in accordance to statutory process that Director Michelle Probert will go over in just a minute. There's a lot of content in nursing home rates, as many of you know, and so we've broken it into 2 sessions, and you should plan to also attend tomorrow. Today, we're going to focus primarily on the direct care component of the rate, and as part of that, we'll talk about case mix, specialty care, and we'll also talk about our proposal for transitional guardrails to get us from our current rate setting method to the new rate setting method. Tomorrow, we'll essentially do everything else, which will include routine and capital components and a draft of our value-based payment approach. There will be time for some clarifying questions today at the end. This is scheduled for 90 minutes. And the Guidehouse folks will also tell you how to submit comments, which we'll be accepting until March 25th. So let's just do a quick review of the agenda. We'll do some background slides about the challenges of the current system, We'll talk about the objectives that we have for rate reform. We'll show you some of the results of the analysis that we've been doing over the past year. We will then talk about our approach to direct care rates and how we're trending it. We'll talk about the guardrails, specialty care, and case mix, and then we will have time at the end for questions. And so with that, I would like to turn it over to Michelle Probert.
Thank you, Paul, and good afternoon, everyone. My name is Michelle Probert. I am the director for Maine Care, which, as you all know, is Maine's Medicaid program, and really appreciate people taking the time to meet with us this afternoon. I'm not going to go through this whole slide, but I just wanted to set a bit of context for those not aware. In August of 2022, a new law went into effect with unanimous support from the legislature. That section of Maine law is 3173J, and we informally refer to it as our Maine Care Rate Reform Statute. And that is the statute that is governing the process that we have been going through for the past year or so, including the public forums that we had starting last year and that we're having today and tomorrow as well, where we have both been working with you all to gather information. We've been doing a lot of analysis of that information, and we're going to be getting your feedback, and the process will continue to go forward. So that's a piece of the statute. It's really a number 3. I'm not always good at going in order. I'll also want to call your attention to number 2, which ensures that we look at the data that we have available, not just at a provider and state level, but also at a national level, so that we can do a good job of making sure that the rates and reimbursement models that we are setting are reasonable. And then the last thing I will note from this slide is that in addition to setting forth our process for updating reimbursement methodologies overall, this statute also calls for services where we determine rates this way and aren't just saying we're going to pay what Medicare pays, that we have an annual adjustment to those rates to keep pace with the cost of living. Okay, so next slide. So I think from conversations I've had with many of you over the past number of years, one thing that we can definitely all agree on is that there are problems with our current system, our reimbursement system, and that has been clear as we've seen facilities close or convert, and that we still haven't seen occupancy get back to the levels that we saw pre-pandemic. In addition to that, there's been lots of conversation around agency staffing, which is expensive and comes with it a lot of turnover, which can have an impact on quality of care. So that's been another consistent theme. Not specific to nursing facilities, but across Maine Care, we also have a goal of making sure that increasingly the way that we reimburse for services takes into account the quality outcomes of those services as well. And our current reimbursement system does not do that for the most part. In addition, with cost settlement systems, there are good sides and bad sides, whether you're speaking from a provider perspective or a state perspective, but we believe that the balance is on the negative side and that needs reforming. The general consensus on a national basis from rate setting experts like Guidehouse is that cost settlement can often result in a lot of variation in a system. And we'll be sharing some data that does show that to be the case. And while we do have things like caps and other mechanisms, the system itself does not always do a great job of providing incentives for cost efficiency. And I will also note that that same system is very administratively burdensome, which you all know. It's administratively burdensome for providers. It is also administratively burdensome for the state. And the variation that we've seen coming out of this system is not always easy to explain, and it doesn't always feel like it is fair. And so we're going to be, or I should say that Guidehouse will be talking about some of the analysis that they've done on that front. Lastly, I'll also note that in addition to being administratively burdensome, the current system does not provide predictability. It doesn't provide predictability for providers. You don't know what the reimbursement is going to be until really you've already incurred all the costs. And it doesn't provide predictability to the state in terms of having to handle the overall budget for the cost of Maine Care services. All right, thank you. So what are we trying to do? Our objectives for our overall rate reform align well with what we're trying to do specifically for our nursing facility rate reform. We really want to be able to ensure that our rates are adequate to sustain access to necessary care. That is a statement for all Maine Care services, and that making sure per federal requirements that we are paying reasonable costs for those services. Specific to nursing facilities, we absolutely have consistently been having conversations about how can we make sure in this rate setting process to provide support for facilities to achieve a permanent, well-trained workforce that is sustainable. So we focused a lot on direct care, and I hope that you see that reflected in the conversation that we have today. We also recognize that having reimbursement methodology that accounts for patient acuity is important. So we have spent a fair amount of time looking at our case mix adjustment method, both to incorporate changes at the federal level, but also, frankly, to recognize the higher acuity that we find among our residents of nursing facilities in the state of Maine. And then there'll be a fair amount of conversations around trend and making sure that these rates can keep pace with changes. Lastly, or second to last, I guess I'll say, we again are looking for ways to tie a piece of reimbursement to the achievement of quality outcomes. So we'll be actually talking about that tomorrow. And again, we want a system that provides more predictability and less administrative burden all around. And with that, I will turn it over to Guidehouse. Thank you.
And thanks, Michelle. My name is Josh Mimm. I am with Guidehouse, and they've contracted us to take a look at all this. And me personally, I was responsible for most of the analysis and modeling. So that's why I'm talking to you currently about that. So the first thing we want to talk about is really what the data showed, right? Anytime we come in, we want to look at, okay, what's the data tell us and where does that lead us? And as Michelle mentioned, it really varies. And I think this is, nursing facilities across the country, it really varies when looking at statewide. And with the way Maine does it with the cost settlement, we really see variation across providers about the gap between, their all payer cost per day and what the state is paying. And you can see that, we range all payer from 242 to 609 with a 342 average. And then the reimbursement is from 218 to 476 with an average of 320. So there is definitely some gap there. And you see it's, mostly concentrated on the right-hand side of the graph. But, there's gaps spread throughout. So it's really that gap that I think drives us a little crazy sometimes. And that's what we're hoping to address here. So Justin, if you want to move on to the next slide. And this kind of, this slide really displays a little bit of the craziness. So one of the things we looked at was, okay, how does direct care cost compare to facility size? And this chart shows it. There is a little bit of correlation there, and it's actually not the correlation we'd expect, right? As you get bigger, we'd expect you to be able to be a little more agile with direct care costs. But in here, the correlation is up. Now, the correlation is obviously weak. But also with the scatter plot, you can see the dots are really kind of all over the place. So we really struggled to correlate direct care costs with a lot of the different measurable metrics that we have. So as you can see on the bullets on the right, you know, there is a little bit of correlation there evident, but it's not strong. And then we also looked at on the geography basis. And there's not a lot of relationship even between rural, super rural, and urban. So that was really a challenge, you know, going forward with what we were trying to do. And I think it informed a lot of this approach you're about to see. So Justin, you can go ahead and move next. All right, and then one of the big things that always comes up is contract labor, right? We hear a lot of facilities are struggling with contract labor. So we really looked at it to say, what level of contract labor are we seeing? You can see the spread here. With different ranges, 0 to 10, 10 to 20, you know, 20 to 30% of facilities. And, you know, there's 31 facilities that have, you know, little to no contract labor, but there's also, you know, 9 facilities that have over 50% contract labor. So there's really a huge spread there. And it's not, you know, it's nothing we could tie back to geography or really any facility type to a certain extent. And we'll see that in the next couple slides. But you know, there's just such a range over everything that it became really challenging. So, you know, I can't emphasize how challenging it was enough, but yeah, so this just demonstrates that. So let's move on to the next slide. All right, so one of the things we looked for on the direct care side was hours per day, you know, your overall cost, and the percentage of contract labor. So in the box on the left, this shows hours per day. And now we've broken this up. We've split out a couple of categories here. We've got all facilities, the veterans homes, and then the hospital, affiliated, co-located, what have you, those facilities. So you can see on this one, you know, the veterans homes definitely have more hours per day. So that, you know, there is some trend there, some correlation there. And then when we look at the middle, the costs, and we have the same breakdowns, right? And the costs are surprisingly, you know, not correlated. Like the veterans homes are a little lower across the board, which would cause you to scratch your head. And then when we look at the percent of contract labor, like the veterans homes are doing a good job of having permanent employees and not relying on a whole lot of contract labor. So this, again, just goes back to almost the lack of correlation, and really just there's so many factors at play here on everybody's cost that it's hard to narrow it down to say we really need to focus on this or we need to really focus on that. So, you know, again, this is really just spelling out how hard my job was, but I don't want to dwell on that. So let's move to the next slide. All right, so the overview of what we're trying to do here, right, particularly with direct care. Right now we do individual rates, you know, based on cost, and there's 110% cap, you know, on this rate, but it is retrospective. We do cost settle. And what we're going to is an hours per day. So essentially a standard base price based on hours per day. And I think, you know, we talked about this a little bit before. Now, before we did cost settle it, and going forward, it will not cost settle because it's a prospective rate. And in the past, we case mix adjusted based off RUGs. In the future, we'll case mix adjust based on PDPM. So the case mix adjustment isn't going to change. It's just the method we use, RUGs versus PDPM, will change. And we'll talk about that on a slide, a couple slides down. But just a quick overview there. All right, Justin, go ahead. All right, so this is where we kind of get into the meat of it. We did base it when we did our math, and I'll show you the math on the next slide. We're budgeting about 4.5 hours per day average for the average resident acuity. So it's really average. This is what the hours per day is. And then we take an hourly rate, case mix adjust that to get the payment. And there's no cost settlement on that. Again, it's perspective. But really the objective of that is to promote quality, right? We want to select a rate that's high enough that it's above kind of the minimums, right? If we looked at the PVJ, the average hourly, hours per day there is 3.78. We're going to 4.48. And then we've got our minimums. The state minimum is 2.93. CMS is proposed a minimum of 3. So we're well above the minimum and above the PVJ hourly rate. And, we really want to promote quality. We want to give you the room to say, okay, I've got, money enough that I can hire who I need to hire. This also gives you predictability and hopefully, reduced administrative burden on that front. And case mix, we're moving to PDPM. Again, we'll talk about that later. And then we are still going to case mix adjust, right? It's going to be normalized. And again, we'll talk about that, I think, possibly tomorrow. But and it just does reflect the higher resident acuity of Maine, right? We do see that when we looked at the data, Maine is a higher acuity, and we're going to compensate for that. So on the PDPM front, we're only doing the nursing portion. We don't want to get into the therapy portions because it just adds complication in the mix. So we're going to just stick to the nursing spot. When we did our benchmark for wages, and we'll see this on the next slide, so I'm not going to get too much into this here, but we are above the 75th percentile of BLS. And again, this is just us hearing you, right? It's a challenging market out there, particularly when you're competing against hospitals trying to get RNs in there. It's a tough sell. And so you need a little bit more room to get those RNs in there. So Justin, go ahead and move to the next one. All right, so this is the calculations that what it's going to look like when we do the HPD rate. So let's start on the left here. There's a lot of information here. So when we talk about the hours per day, how did we come up with that? So what we looked at from the cost reports, the 2022 cost reports, is how many hours per day. Again, this is hours reported divided by total days of each level of nursing, and then contract as a whole, just because that's how the reports were structured. How many hours per total day are in the cost report, and that's where we came up with our 4.48. And then we broke that down by percent, which we'll get to in a second. So that's how we came up with our hours. And now when we talk about the average compensation, this is a little bit trickier. So we put the BLS data up here for comparison. The median you can see there and kind of in the middle. And then we show the 75th percentile. So you can see even the average is above the 75th percentile of BLS. So that circle in the middle shows the average wage that we're using in our calculations. And then to the right of that, we add a certain amount for benefits and taxes to get up to essentially the hourly cost of nursing per resident, right, at each level. And then we combine the left and the middle to get the percent of total hours. And then through that, we essentially calculate an hourly cost of each level. So we get 40.98 per hour, and we multiply that by the hours per day to get a daily rate. And this is just the hourly, cost daily rate of 183.59. And I'm sure there'll be questions, so we can come back to this, but I want to continue on because I think some of the questions will be answered by the next slide. So that's how we get to essentially our rate per day based off 2022 cost report data. All right, so go to the next slide, Justin. All right, so then once we have our hourly rate, or our daily rate of the direct care nursing cost, there's still a chunk out there that isn't accounted for. And that's with this slide details is there's other stuff. There's activities, there's supplies, things like that. And so we've set that at 10%. So you can see with 10% out there, we add another 10% onto our hourly calculation for nursing, which gives us the 203.99. So we start at nursing and then add on the other stuff. Okay, and then go to the next slide, Justin. All right. So then our 203.99 carries forward, and now we trended forward, right? And this is, I think, what Michelle was talking about. let's talk about the trend. How do we get to $2025 from our 2022 cost reports? And Erica is going to talk about this when she gets involved here. But we added a 9.21% overall trend to go forward. And then the base rate, is 222.77. Now this is going to be case mix adjusted, right? So we can recognize, hey, I've got sicker patients. It's going to show that, and we are still going to case mix adjusted rate just like we do now. But again, this is paid prospectively. So it's a little bit front loaded with the trend, but there is no cost settlement. Okay, and then move to the next one. All right, and this is where I hand it off to Erica. So thank you, Erica, for saving.
Thanks, Josh.
Of course.
So we're not going to spend a ton of time today on this particular slide. We've been focused on discussing the direct care portion of the rates. Tomorrow, we're going to be pivoting from direct care to the rates in totality. But we wanted to make sure that you all going in tomorrow, while we're just talking about direct care right now, that you understand the overall trend framework that this direct care trend fits in. So really wanted to make sure in particular that all the stakeholders have a deep understanding of the different trend indices that we are pivoting off of for the purposes of this trend development within the nursing facility rates. So on the direct side, and we go into this in more detail in the following slide, we are using CPIW Northeast, and we are looking at an August over August per the direct care for Part Quadruple A. For electricity, heating, and routine. So historically, for other states, we have not broken out electricity and heating separately, but we really heard the stakeholders' feedback. That is something that has been an immense pressure for all of you. And so we wanted to be sure to give that appropriate consideration. So for electricity heating, we use the CPIW, CPIU Energy Services Northeast level. So while there isn't a Maine specific index, we did want to be conscious of the fact that the experience of the Northeast certainly is different from the Southeast or Texas. And then the routine component of the rates is trended using the Producer Price Index nursing care facilities. For the fixed costs, that is cost settled, and so the trend development is moot. What you all spend will be cost settled on the back end. And then wanted to remind the group of how we are taking a look at trends. So Josh noted we are using 2022 cost reports. And so what we are doing is, since we already are through calendar year 23, we know from these indices what the actual trends were that went from 2022 forward to 2023. So rather than us estimate that, let's actually use what's known. Let's go ahead and use the indices. But then when we are trending from 2023 to 2025, those are projected trends, and those are based on us reviewing and considering the most recent experience that is occurring within these indices, as well as feedback from the stakeholders. So if we move forward to the next slide, this is where we focus specifically on trending the direct care buildup that Josh walked us through. Here you'll see the trend that we are using for the direct care, as I said, is CPIW Northeast. And that index was selected for consistency with Part Quadruple A. So that ensures that the labor components of the rates are at least 125% of the minimum wage. The minimum wage increases are based off of an August over August CPIW Northeast increase. So wanted to call that out for any of you who want to go back and kind of check our math. Wanted to make sure that was clear. So if we go column by column, the actual calendar year 22 to 23 trends, that's us looking at August 23 over August 22. CPIW index, and that's 2.5% annual trend that occurred for that time period. And then the next phase, as I said, is us projecting what the trends are as we move from 23 to when the rates will be in effect over the course of calendar year 25. That 6.5% trend that you are seeing there, that equates to a 3.2% annual trend. The last 6 or so months, trends have actually been a chunk below 3% for CPIW. But if we put ourselves kind of in the shoes of the Fed and what the Fed has been saying, I think historically our Fed has said 2% trend is really 2% inflation is really what we're targeting. But we wanted to be mindful of the fact that, you know, what we have seen in the past couple of years, it has been a little higher than that 2.5. And so we wanted to be sure to provide appropriate consideration in our projections. So multiplying together that 2.5% annual trend times 1.065, the trend that takes course over the projected trend that takes course over the next 2 years, that equates to 9.2% in aggregate. I think we can move to the next slide.
Is this me or are we handing it back to me? I'm happy to take this slide. I think this might be Paul. But I'm happy to take it. And if I don't hear from Paul, I will keep talking. Paul, you're on mute if you're trying to talk.
Yeah, no, but go ahead, Josh.
Okay. So for this, one of the things Maine has decided to do is put some guardrails in, because we understand that, you know, if you looked at one of the slides, you saw that just the discrepancy between rates. And so when we're introducing, you know, this HPD rate, we understand that it's going to be some significant changes. So what Maine has decided to do is limit the changes to really 10% year over year. And this is applied to both direct and routine components. You know, we're just talking about direct, we'll talk about routine tomorrow. So in the first year, the transition is really going to be based on either cost or previous rate, right? Because we want kind of an honest look at what are you really doing, and we're going to try to do the best we can there. After the first year, it's going to switch to just the previous rate. So year over year, you move 10% if you move. Like, you know, a lot of providers won't after the first year, but you know, there is some movement there. So there are going to be guardrails on that. And then this is independent of inflation. So everything will be adjusted for inflation. So if you look at year to year, and they're going to inflate both to look at the guardrails, right? It's not like inflation counts towards your guardrails or against your guardrails. And then as noted here, it'll be 3 years. So you can look at it's kind of a simplified graph, but essentially if you look at yourself in the middle, that's your current rate. And the new rate is on either you're going to go up a bunch or you're going to go down a bunch. The guardrails are going to kind of constrain that. So you'll only move a certain amount. But then, you know, the next year you'll start at that amount that you moved to, and then you might be out of the guardrails at that point. So that's kind of how the guardrails look. And again, at the end, I'm happy to answer questions about the guardrails, because that's kind of what I did. So I know it can be a little confusing. So, all right, go ahead, Justin. All right, and I know this one's not me.
This is definitely me. So, wanted to talk a little bit about how we're going to approach specialty care, and split it into a couple of areas. First, I'll talk about bariatric and ventilator care, and then we'll talk about the brain injury and med psych units next. For the bariatric care, we'd start with the new base price. It would continue to be case mixed. And the change here, will be that we're moving toward a standardized add-on in tiers for extraordinary staffing needs. Those of you who have engaged in the prior auth process know that currently those extraordinary needs are approved. You know, each one is a one-off. It's very administratively burdensome for both you and for us. And so we really want to try to standardize that add-on. And we're almost finished developing what that add-on would be and how many tiers and so on. You all would continue to bill for DME as needed related to bariatric care, and any capital investments that you need to make would continue to be recognized in in the cost settled capital expenses. Capital is the one area that will continue to be cost settled in this approach. Ventilator care, again, not a lot of change here. You start with the base price and case mix it. We already have a standardized add-on for ventilator care, so that would continue to be the case. And again, we would continue to recognize capital investments that are associated with ventilator care. And so our hope here is that this will help promote more timely access by having standard predictable rates and reduce the administrative burden for both us and for you. Moving on to the med psych and brain injury on the next slide. Here we need more time. These are both areas where we need more capacity. You may know that we have people with brain injuries that are currently living in out-of-state nursing homes. We would love to bring them home. And, you know, med psych is an area where we probably the majority of people waiting nursing home placement who are stuck in hospitals have behavioral needs. And so we need more capacity in that area as well. We also know from our experience in both of these areas that we want to rethink what the specifications for the service are. And so, for calendar year 2025, we will update, we'll do some more work. We have to redo the specifications for each of these services to make sure that they reflect current best practice. And, you know, now that we're moving toward an hours per day, what would the hours per day be typically for people in these categories? What would the credentials of the people be that would be providing the service? So we need to spec that out so that then our actuaries can price it out and we can move in 2026 to a specialty specific price and eliminate the cost settlement. Until then, we're going to essentially stay with our current reimbursement policy for both of these areas and get to this over the next year. And now we'll turn to Kathy McGuire to talk a little bit more about the case mix adjustment.
Yes, hi, Catherine McGuire, and I'm working on the case mix adjustment with the department. And as you've already heard, Maine will be transitioning to from our current resource utilization RUGS 3 group to the CMS skilled nursing patient-driven payment model, PDPM, and we'll just be moving to the nursing component of that model. In the fall of 2025, CMS is no longer going to support the data elements required to calculate the RUGS classification system. As some of you are aware, last fall, as a stopgap measure, we implemented the other state assessment, which is the OSA form, in order to capture those data elements to continue to calculate the RUGS 3 classification system until we can transition to the PDPM. The PDPM will continue to be supported by CMS and the MDS 3.0 elements going forward. So Maine Care proposes to use the case mix, the PDPM nursing component as the direct care case mix adjuster. The department will also be standardizing the PDPM nursing component weights to reflect the case mix of Maine residents in nursing homes. And so individual weights will be calculated for each of those nursing PDPM groups relative to the normalized state average. So there's a lot more to be learned and to provide information on, and the operational changes that this implementation will require. And again, this is all anticipated to go live with the rates in January 2025. And I think back to Guidehouse now.
Yep. So we are going to open it up here for questions in just a minute. Questions, comments, clarifying questions, but did want to do a quick walkthrough of how you can submit your comments after today's presentation and tomorrow's presentation. I'm sure as everyone gets a chance to dig into the PowerPoint, you will have additional questions. And we went in and set up a Microsoft Forms survey to allow us to be able to more quickly and efficiently respond to questions rather than just getting a bunch of emails in. So within the presentation, and then we'll also send a link to this, you'll find this form survey where if you just click on it, does everyone see Maine provider comment survey now? Instead of the presentation? Yep.
Oh, it's still the slide.
Still the slide? Okay, let me.
I think you have to share that other screen.
All right. All right, now let me reshare it. How about now?
Yep, we see it, Justin.
Okay, so everyone will be given a link to this survey, and then we'll just ask for your name, organization, your email address, and then this is laid out just along the agenda items that we had today to allow us to sort through questions easier. So I won't walk through all of them, but essentially if you had any questions or comments on the challenges of the current system, you could hit yes, and then a Dropbox will open here for you to enter whatever you'd like to say about that. If you did not have any comments on that, you just hit no, and then the next agenda item will pop up. So if you have any questions on rate reform objectives, hit yes, and then a drop down will come in and allow you to answer questions. And then this will go all the way through each agenda item today. So by filling it out this way based off agenda items, this will populate on the back end for Guidehouse based off of these agenda items and allow us to sort through much quicker and get questions answered much quicker. So you'll receive that link, as I said, in the email, but it's also in the presentation as well. So just wanted to show everyone that real quickly. And then let me go back to the PowerPoint. And then before going to comments, just a few next steps here. We will have the second meeting tomorrow afternoon. As I said, we can submit comments through that survey through March 25th. And then DHHS will decide if additional meetings are needed as we move forward. So I think at this time we can open it up, Amanda, for questions. I did get one, it looks like in the chat here. And I think Michelle answered it. I'm not sure everyone could see this, so I'll just read it quickly. When Wanda asked, will payment rates still be based on case mix score by resident? And okay, this is very oddly sorted. So that was the first question, was from Wanda, will payment rates still be based on case mix score by resident?
I think we can jump in and answer that. The answer is yes, and I actually was hoping we'd be able to spend a little bit more time talking about case mix to highlight a bit of what Josh said earlier. And so one thing that we're doing differently is recognizing that the acuity of our nursing facility residents in Maine is higher than in the rest of the country. We are normalizing the case mix index to the state of Maine. And what that really means is that our average acuity, and keep in mind that the staffing hours that we showed are based on the average. So our average acuity is going to have a case mix of 1.00. And so the average rate goes to an average acuity person. If they have higher acuity, then that will go up. Lower acuity goes down, but it recognizes that the Maine average is higher than the national average, so that things are getting adjusted accordingly. It's can be complicated to explain, and I'm not sure I just did it well. So welcome a follow-up question, or if someone else on the Maine team, feel free to take a crack at explaining that better.
And Amanda, I think if you could open up for folks to chime in with questions, rather than have everyone type them in. I've only gotten 2 others typed in, but I think if we can have everyone ask their questions, it'll be easier for everyone to kind of understand.
You mean set it up so that they can, I don't think I can change how the chat's set up.
No, just so that they can actually speak into the meeting. Like if
Yeah,
Angela
Angela has a
ever
question.
unmuted, yeah.
Thanks, everyone. Thanks, Justin and team, for that presentation. We appreciate the time and the opportunity to have this dialogue. Angela Westhoff with the Maine Healthcare Association. Sorry, I should have introduced myself first. Could we, I don't know if you have the ability to go back in the slide deck. I was wanting to seek some clarity around the slide on direct care, how it works. So you have average wages from the BLS data set. I'm wondering specifically on the contract labor piece, that 7156, where did that come from? Is that off 22 cost reports?
It is. It's the average off the 22 cost reports.
And is that the average of all positions like CNA, LPN, RN, OT?
Yes.
Okay, so it's an average of all contract labor, regardless of where they fall in a category. Excellent. Thank you for that. Is it okay to have a follow-up?
Sure.
My follow-up question is then specifically around, I think it's 222.77, which is maybe the next slide. Maybe the next slide. Yeah. Okay. So we have the base rate, and I understand that you're trending that forward. That's how you end up with the 222.77. So case mix would then be added to that, depending upon the acuity score. Okay. So that's kind of the part we don't know today, right? Like, because we wouldn't have access to MDS data. So we don't know how much that rate would go up or down, depending upon acuity. Is that fair to say?
Yes, that is fair to say. And very
Okay.
similar to how you do. The only exception would be the normalized case mix, but yes.
Okay.
Though, Angela, don't facilities generally know what their average acuity is?
They do. I don't.
Yeah, right. Okay.
So like when I see what our average rates that are case mix adjusted, the 222.77 looks dramatically lower, right? Because I'm looking at that average statewide rate with the acuity built into it. So it's over $300. So I'm just trying to get a flavor for how this will be in the real world. And Paul, I had sent you an email asking for some data, so maybe I'll follow up with you again on that. But I think it'd be really helpful to Maine Healthcare Association and to our members if we could kind of see what that crosswalk's going to look like with the acuity piece built in.
And I'm probably saying what you already recognize, but just for clarity for everyone, this is a single component of the rate. So there are 2 other components to get that. Yeah.
Yes. Yep.
And then if other folks have questions they want to ask verbally, if you could just put your hand up, and then Amanda, hopefully you can unmute them.
Yep, looks like Olga.
Sure, thank you. Olga Gross-Balzano. I work at Berry Dunn, and we work a lot with data and cost reports. So I want to follow up on Angela's question a little bit. What we see is huge unpredictability of contract labor by discipline. And what's happening in Maine is providers really do not have any ability to control supply of that contract labor. So as much as somebody, if they can have an LPN, but all that's available is registered nurse, it's a much higher cost. We do not have a mechanism on cost reports, nor we have any data available for state of Maine to understand what levels of care are needed, what supply is, and I honestly have significant concern about 10% of the rate being kept at a certain number without adjustment for need of the facility, whether it's registered nurse or LPN or CNA. And 10% may look like it was reasonable in 2022. However, based on conversations with facilities in current day, that does not appear to be a trend. We looked at PBJ data, and some counties have 30, 40, 50% of contract labor at the facility. So limiting that at 10% and $7 a day seems absolutely unrealistic number. Any comments on that, on approach? And
Yeah, what I'm happy to
Thank you.
start on this one, Olga. Thanks for the question. One thing there does seem to be consensus about is that contract labor is a big issue, a big problem, right? And it's not, it's really two problems. It's a problem with the cost that it adds to the system, but also that when you have a high percentage of contract staff, it's impossible to work on quality because you got people cycling through the institution who don't know the systems, the processes, and so on. And so we do have, you know, the largest number of facilities here in this slide are at 10% or less. So it is possible, and we feel pretty strongly that this is an area that we all need to work on together, because just assuming that the existing levels of contract staff is sustainable or something that we want to continue, I think is not something that nursing home residents or operators can tolerate over the long run, and it adds cost to the system and diminishes quality.
All right.
I
I
have a
think
question.
Amanda, you're on mute.
Yeah, sorry. I have a question from John, who's attending by telephone. And given the historic and dramatic underfunding of nursing facilities, shouldn't the guardrails be more appropriately 0 to 20%, as any facility facing a 10% reduction may face foreclosure?
And just, and I'll jump in real quick. And the 10% is from your current rate or cost. It's not from the rate itself. So you're actually just moving towards the rate. So you're, instead of getting like 20% from your current rate, you're only getting 10. Does that help?
Does it make sense to move forward to that slide to sort of have all the conversation together?
And I think if I understood the comment correctly, that the suggestion was that it should be no losses and up to 20% gains. That's how I interpret the comment.
I'm sorry, Michelle, then you're probably right. Yeah.
A clarifying question that had come up in a previous conversation that I'll just share for awareness is that in that 10% comparison, we are trending forward what the costs are to be equal to what the new rate will be, so that it is apples and apples. I know that doesn't, just so you're fully informed of how that comparison would work, but we appreciate your comment and encourage folks to submit those comments through the forum as well.
I have one more comment from Kathy Rose. Some nursing facilities didn't use contract labor because it was just too expensive. When looking at agency staff utilization, did the reviewers look at occupancy at the same time? This is like a 3-part question, so we'll start with that one.
Well, I mean, I'll start by saying if you're a facility that didn't use any contract labor, then this rate system will benefit you, because that 10% assumption will still be built into the standard price, and you won't need all of that money because you know, you can apply it to your regular staff.
And I'll say we are going to be talking more about occupancy tomorrow, I believe. Is that correct? Yeah, so we might want to save going into detail on occupancy questions until we actually get to that content tomorrow.
Yeah, I'm sorry, this is Kathy. I asked that question because I have 2 nursing homes, and one of them didn't utilize contract labor and couldn't fill their beds because they didn't utilize contract labor. And the other one used contract labor in spite of the cost being far in excess of their ability to get paid for those services. So I was curious why, how we got to having a penalty for contract labor in spite of the fact that there's no labor out there and that contract labor was the only option some of our nursing homes had. So I'm open to further discussion on that at a later point in time, but that's why I asked that question.
Did
Thank
you want to go ahead and ask your other question?
Sure. I have 2 other component questions. One of them is just a general question. Will we be eliminating all of the peer groups in this process and having one set of rates across the entire state? So we won't have a hospital-based group, you know, a large nursing home group and a small nursing home group, but we'll just have one set of rates everywhere?
Yes, that's the current proposal. We didn't, I mean, as you saw from the early data slides, there's no, it's very hard to document any rational relationships between costs and size of facility or location of facility. You definitely do see for the hospital based, what you see is both a higher rate for contract labor and higher use of contract labor.
Can we go to the, sorry, I'll interrupt, but can we go down to the next slide?
This one?
Next
Nope,
one.
next one. There
This
we
one?
go. Thank you.
Okay.
Yep. I don't think that we actually spoke to the second bullet point here, but we were looking at nursing facilities related hospitals to see if there were significant differences there, and there were some differences, but as Paul noted, we didn't think that, for example, it would make sense to build into a rate contract labor at over $100 per hour for hospital-based facilities and not for other facilities. It seemed like where we found differences, it didn't necessarily seem to make sense to bake that into a peer group. In addition to Paul noting that the size relationship was the opposite of what we would expect to see, and we also didn't see a rational pattern when looking at geography. So when we were trying to figure out, like, are there ways to categorize facilities and differ the payment, we weren't finding significant differences that where we felt that it was going to be good practice to bake those differences into the rates. It was not our original objective to have a standard rate, but that is where the data led us.
And if there's time, I have one more question, and that has to do with the use of PDPM.
Sure.
Are we planning to use the federal PDPM categories, but assign our own weights and rates? Or are we going to use the federal data that's published October 1 of every year for our January 1 updates, and then assign our own case mix weights, but use the federally established relationships? You know, how they have a weight assigned to each category. Are we going to use those federal weights, or are we developing our own at the state level? I just want to understand how much we're going to use the federal PDPM data.
Should I take that one?
Yes, Kathy.
Yep. So for the standardization we did with our cost data, we use the weights that are assigned per group, per classification group by the feds for the 2022 year, and standardize those for the case mix for Maine residents. So we started with those weights and then created the standardized weights based on that.
And will we update those annually, or will they be fixed at the 2022
I think
distribution, if you will?
that I'm not sure that decision's been made yet.
Okay, thank you.
Yeah.
And we are happy to take comments on if you think annual updating makes sense, et cetera.
I think Wanda, you were next.
Thank you. I'm Wanda Pelkey, and I'm the CFO for First Atlantic Healthcare, and I have a couple of questions for the group. And I think the overarching question that I would have, and maybe this is more of a question for tomorrow once you finish your presentation about how the whole rate setting system works. But one of your, your primary objective here is to make sure that these rates are adequate to sustain access to services. And we all worry about that, right? And we have had a lot more closures than any of us would like to see. And so this whole rate setting process is supposed to fix this. And so my question is, have you modeled what these rates will be on a facility by facility basis against the projected costs for those same facilities, to understand which facilities would be adequately paid or have a substantial shortfall that would imperil their survival?
So first, I'll just say that absolutely we want rates to be adequate, and we also need them to be reasonable. And I just wanted to restate that when you see such a degree of variation in what the costs are, that creates a dynamic where it's probably not reasonable to bring all reimbursement up to a level that would cover the highest costs, right? And that probably would have some problems under a system that's not cost settled with upper payment limit. So I just wanted to kind of set the context for what we're trying to achieve here, right? Like we would like less variation in the system than what we see right now. So we are doing comprehensive modeling. We need to do that to understand fiscal impact to the state, but we'd like to focus the conversation on the inputs to the model in terms of hours and percentage assumptions and everything else, so that we can judge on the merits. Like, do we think that these are reasonable benchmarks? And if you have feedback for why these hours or that percentage are not reasonable, then we are very open to hearing that feedback so that we can assess that.
Okay. Just an observation, I look at PBJ data as well, and the most recent PBJ data that's published now on the web is the third quarter of 2023, and the statewide average agency use in that period is around 24-25%. So just to give you some context against the 10% that you're building into the rates, I agree with Kathy. It's not as easy as you might think to control the amount of agency spending when you're working in an environment with workforce shortages. So if that's the average and you're kind of setting a bar at around the 75th percentile for some of these cost areas, then, I guess my suggestion would be just kind of take that into consideration, that you may not have enough cost then built in to take care of those agency costs. And then the last comment that I would have is around, if you're trying to reach for what other correlations there may be. And I fully understand that you're finding a very weak correlation between cost and the size of the building. My question to you would be, have you correlated the cost per patient day to agency use? Number one. Have you correlated cost per day to the hours per patient day for services that are rendered? So, kind of holding our Maine vets homes here in the slide that we're looking at is a good thing, right? That they're able to provide a lot of hours per patient day, and yet their costs seem like they're fairly reasonable, if I'm reading this chart right. So, is there some correlation between hours per patient day and the cost, the overall cost? And then I'm wondering about geography, you know, by region, is the cost per patient day or maybe the rate of labor per hour higher in certain regions of the state than others? So if you haven't done those correlations yet, I'd be curious to see what that would look like.
Yeah, and Wanda, so there absolutely is a correlation between hours per day and cost. I mean, we know that a lot of costs are driven by staffing, and so if you have higher hours, then generally that's going to be more expensive. But as you note here, it's not always so straightforward, because if you have higher hours, but if you have lower per hour compensation costs and lower contract percentage, then it may not always be. So nothing's ever perfect, right? But there's absolutely a correlation with the hours, which is why we tried to make sure that we were in a solid place with the hours that we were using. PBJ data and cost report data, we did a fair amount of work to understand those different sources, and in theory think they're supposed to measure the same thing, recognizing that that can be hard sometimes, especially when you're reporting in different ways and in different frequencies. And so we just went with the higher number to you know, make sure we were providing that support. So that's an hours per day. We did a fair amount of analysis looking at geography, including looking at BLS data, and we were not finding that that rural, non-rural, super rural, there was not like a rational relationship between that and the different rates that were being paid for wages. Because if there were, and if that was going to help, we wanted to make that adjustment, but it was not helpful either. So the fact that our wages are well above 75th percentile BLS data, we felt pretty good about, especially because our standard practice in rate determination is to look at median BLS data, but we felt that it was defensible to look at what the actual data is, in part recognizing that we have that requirement to pay 125% of minimum wage as a floor, and that obviously is not reflected in BLS data. So those were some of the conversations that we had. And Wanda, did you was there another component you asked about that I missed?
I'm sorry, I didn't catch that last bit, Michelle.
The first thing that you had asked about, I didn't quite hear you, and so was there something I missed in my response there?
Oh, around the just the correlations with the agency use to cost. That was one of the
agency use. Is that agency use? Is that what you?
Yes.
Can you say more about that?
Yeah, so I think we're all hoping to avoid any unintended consequences, right? You know, so I'm just wondering if there are some areas of correlation that you haven't analyzed, and it sounds like you're open to, you know, if there are some areas of correlation that are very reasonably driving costs, that you would consider that in this rate reform work if it's not already considered. Is that in essence what I'm hearing from you, Michelle?
If you find we've looked at a lot, but certainly I think when you're saying, and sorry, sometimes we use different words, even though they seem straightforward. So when you say agency use, can you just give me an example of what you mean by agency use and how that would correlate with cost?
Yeah, sure. You know, so you have one slide here that shows the, you know, maybe penetration of agency is maybe a better use of the term, but 31 of them, I think, on that slide had 10% agency use or less, right?
Okay. Sorry, when you said agency use, I haven't heard that as a term for contract labor or temp agency. And so I was missing what you were talking about. Now I understand what you mean.
Yeah.
Okay,
you know, so,
on the same page.
So yeah. 31 out of however many there are here, 90 or so, right? 31 have 10% or less hours being filled with agency workers, meaning that, you know, 60 have more than 10%. And those would likely have higher cost per patient day.
I think the key on this one, Wanda, though, is that, I mean, and you said it in your question, reasonable, right? So is it reasonable to pay 70% contract labor for those 3 facilities? That's what we're struggling with. I think,
Yeah.
I think we all recognize that contract labor is one of the big keys to making this all work here. So we would love your comments on that.
Tammy?
Hi, I have a couple of questions. Well, one's a comment really based on your last comment, Paul, about, what is a reasonable rate for contract labor? And I'll just comment that the reality is if these facilities don't pay what the agencies are requiring them to pay to get people in the door, then more people will be stuck in the hospital. So, which will cost, the whole healthcare system more money. So the question of reasonableness needs to be looked at in a more broad perspective as to cost to the entire system. Nobody wants to pay exorbitant amounts for agency labor, believe me. But when we think about reasonable, I would urge everyone to think of it from a broader perspective. The more, if we pay high rates for agency labor, it's still less expensive to care and the right place to care for a resident in a nursing home in a lot of cases than in the hospital. So that's just one comment I wanted to make. The other was on the regionality of costs. If we could go back to that slide about direct care costs for most facilities and versus MVH and that kind of thing. We at Barry Dunn, as you know, do a lot of analytics. Right there. Perform a lot of analytics and database work based on all the cost reports that are filed. And we do see a significant difference in the RN and LPN wage rates between regions of the state. In fact, the information that I have from 2022 shows that RNs in Region 1 on average are paid $10 an hour higher than the lowest region in the state. And the same, it's $9 differential for LPNs. CNAs don't have a large differential, and I'm surmising that that's because of the minimum wage requirements and the 125% of a minimum wage. But there are significant differentials in wage rates for different regions in the state per the as-filed cost reports. So I just wanted to make that comment, and I'm happy to talk to somebody about it further if you wish.
And Tammy, if you're also willing to share that as a comment, that will be helpful.
Sure.
Mary Beth?
Hi there, Mary Beth Dano from the Barron Center. I wanted to echo what Tammy was saying, in that, if we don't, as a facility, pay the rates for the agency staff to come in, we don't get them. They'll just go to another facility. Has the state of Maine ever looked at capping the rates that agencies can charge? I know other states have done that, and I think they're enjoying a little bit of success in that it's not highway robbery there anymore.
So Mary Beth, that request has been made many times. I think there might have even been legislation to that effect, and there's a lot of concern that it doesn't work. I mean, the one example that I'm familiar with was efforts that were being made in Massachusetts that didn't work. So we would love for you to send the comments of states where that's working as a strategy so that we can reconsider, but we haven't seen it actually working as a strategy, though I appreciate the intent behind it for sure.
Thank you.
Rick?
Thank you. Question to Guidehouse. The 75% percentile to the BLS data for Maine. No local state, adjacent state, or mid-Atlantic uses this approach to direct care. Can you provide any other state or the number of states that are using the BLS data to develop direct care?
just want to clarify that we're not actually using the BLS data. We're using the cost report data. We were just pointing out that in the circle you see here on the slide, that the wages we're using are well above the 75th percentile of BLS data in all of those categories. So it was just a comparison point.
Okay.
And generally speaking, we often do use BLS data in part because many services where we're setting rates don't have cost report data. So it's a solid source.
Okay. Well, I mean, I was just Googling the BLS data and they indicate that small portions of areas, it's not consistent data there. And again, rural Maine would probably fall into those conditions, the outlier areas. So I kind of question how reliable is that 75th BLS percentile? You're using it as a comparison, but again, we don't know understated, overstated. Okay. Another question I have, and I don't know, this goes to Maine Care. When they talk about the 10% corridor, right? The guardrail. Okay. In comparison to the rate, there is mention that your rate may not change July 1st. It's going to be a lump sum payment. So is that lump sum payment being excluded from the guardrail, which is basically a lump sum payment of the provider's rate for 6 months?
So we are not going live with this July 1 to confirm that statement. And I think your question is whether we would be factoring in a supplemental payment if that is approved through the legislature, or whether we would be factoring in a supplemental payment in the comparison between the rate that is going out compared to what the facility received. Is that your question?
Correct.
I'll look to the team just whether or not we included supplemental payments in how we've been thinking about doing that comparison currently, or if that's one we need to get back to folks on.
Benjamin?
Sorry, I guess since there's not an answer, we'll look at the current assumptions and we'll answer that one in follow up. Rick.
Hi, thank you. Ben Hawkins from the Maine Healthcare Association. Thanks for the opportunity to comment. Really intrigued by the geographic variation and the understanding that it doesn't seem like there's some trends that make any sense. Are there plans to share more of that analysis?
Our focus has been on the content for these 2 days, and so we don't have additional analysis to share at this time.
Okay. And so for the future model, there won't be any consideration for geography, including like the island rates?
I mean, I think we're looking for comments in that area, like, Tammy commented on this as well, and maybe willing to share what she's seeing in terms of geography. Mandy, you're muted.
Sorry. So Olga is asking if there are any provisions for compensation for care of dialysis or substance use recovery patients with significant transportation needs.
Again, I would encourage her to submit a comment in that regard. The current model that we're proposing doesn't offer any special consideration outside of what case mix would do.
And then John is asking, stating the three facilities that are using the highest level of contract labor are not doing so out of choice or preference. Yet supporting those facilities as well as the others is supporting fewer residents in hospitals and providing better care at lower costs. High utilization should not be punished in any way.
Thank you for that comment. And I will just say that tomorrow we will be talking about ways in which we will be providing incentives for higher main care utilization as a piece of this. I know that doesn't address the whole comment, but wanted to note that.
And then I have a couple of comments in here from Glenn. They're fairly lengthy. And we will take down all these chat questions that did come in and make sure we address them, but kind of the high level of the first one is, will there be a process such as the current extraordinary circumstance to give providers the opportunity to request additional funding over the 10% guardrail level, as most are completely reliant on the labor market for a certain region or community, sometimes outside the provider's control? So that is something we will take away with us. There's another comment about when COVID outbreaks occur, agencies are pushing surcharges onto providers, and we are limited and many times forced to pay. This adds to the function of allowing some options to address extraordinary circumstances. So I think that's a continuation of the first observation or request above the regarding the 10% guardrail. Another one from Glenn. We appreciate that the inflation calculation, there seems to be a recognition and acknowledgement of more realistic inflation trends, but what is the factor specifically for labor moving forward in 2025 and beyond? I understand the utilities and energy are set, but labor is slightly confusing. Can you clarify? Thank you.
I think if I'm understanding the question, for direct care, it would continue to be the CPIW going forward.
Right. And then another question from Sharon. Can you clarify for the group that MVH has to adhere to regulation that others do not, which may be impacting this data?
Sharon, your point's well taken.
Those are all the other questions that I received. It looks like Rick may have his hand up.
Yeah, I'll be brief because I already, PDPM. The Medicare PDPM model was based on subacute care and is set on diagnosis codes for everything. When we get into the Medicaid long-term care population, there is a significant portion of the population that is behavioral, cognitive, and it doesn't fully flow to the PDPM score for what's happening because the model was based on acute and long-term care. I know the National AHCA Association and different groups are trying to address how can we model sort of more of a Medicaid PDPM model, long-term care, not a subacute Medicare PDPM model.
I think Rick, submitting comments on that we understand that PDPM was developed for Medicare, and that's why we specifically want to use the nursing component, because that's an appropriate thing to look at in terms of how much care a person might need, as opposed to the skilled therapies, right, which are not going to be as relevant to the long-term care population. And then we're trying to balance administrative burden again for you all and for us. going to PDPM means you can use a part of a system that you're already using as opposed to us continuing with a unique system. So those are the trade-offs we've been talking about on this.
And the nursing component more aligns with the original RUG 4 system, which again was a modification then above the RUG 3 system. So to that extent, and as Paul said, it's not utilizing the points that are more related to the skilled patient. But I think you found it.
All right, and we have 3 minutes left. And then again, we'll be joined by everyone again tomorrow. So Olga, it looks like you may have one last question.
I do have one last question. So as we are talking about PDPM, so PDPM, as we know it, has very important component with it, which is non-therapy ancillaries, which adds a lot of clinical weight that is not reflected in nursing component of the rate. It is comorbidities that are exceptionally important for long-term care population. It is those comorbidities that are creating a lot of additional stress and pressure on facility in delivering care that are not addressed in clinical component of the rate. Looking at this model, it doesn't appear that there is that differentiation for additional needs related to needs of patients that are just not straightforward physical care. So I would encourage you to consider that. And also as a note on data, I know you already put a note to look at that, but 2022 had a lot of supplemental payments that were not just Maine Care supplemental payments, right? There were FEMA funds that a lot of facilities used and reduced expenses by those one-time payments from FEMA or some other sources. So it is my understanding, working with state data, is that some of the costs are not really representative of what current situation is because there were additional funds used and they were offsetting the cost of care in 2022. And another moment is when you look at correlation of facility, different areas and number of beds, a lot of facilities closed units. So they do have, say, 70 beds they're licensed for, but they only used half of those beds because they couldn't staff them. So when you look at the correlation of size of the facility and cost, in 2022, those are very much skewed because that's not, not all the beds are occupied because there's no staffing for those beds. And when we look at newer facilities versus older facilities, the size, especially in routine costs, newer facilities that have private rooms, larger general areas, more opportunities for socialization, like, I don't know, theaters and whatever, the routine costs would be higher per patient day because the physical plant is very different. So that's another thing to consider. And I hope that adds a little bit of insight into the data and why it cannot really be correlated based on number of patient beds, because not all patient beds in Maine are the same.
Thank you, Olga. And we are at time. So again, we'll be meeting tomorrow to do the rest of the rate components. Again, I encourage folks that have comments or clarifying questions when you get a link to that survey to submit your comments. And then just noting as you get to the bottom of that survey, there is a catch-all. If you have specific comments that didn't fit into one of the agenda items, there's a catch-all at the bottom for general thoughts and comments. So appreciate everyone's time today. And we look forward to discussing with you again tomorrow. Thank you.
Thank you.
Thank you.